Hi, guys, and welcome to another episode of the Meet Medic podcast. Today, I am interviewing my very special guest, Dr. Malini Bose. I think that's how we say
Yeah.
your name. I apologize if that's incorrect. Dr. Malini is a GP, and she's been here now in Australia for around 7, 8 years. And she's actually just recently started up her new business, the PheonixDocs, which looks amazing. And Malini would like to give us her story and tell us a little bit about herself and what she's trying to do to help people out there. So, Malini, can you give us a little bit of your background?
Yeah, thanks for that. And thanks for having me today. So I am a GP. I fellowed with the Royal Australasian College of General Practitioners, RACGP, in 2020. And since then, essentially have been practicing, actually, even before that, practicing more holistic medicine with a focus on lifestyle and nutrition and practicing low carb medicine for various purposes. Um, and to the point where I'm now pursuing two fellowships. So, one with the Australasian College of Nutritional Environmental Medicine, or ACNM, and concurrently with Australasian Society of Lifestyle Medicine as well. Um, and other than that, I'm now also, yeah, I've just launched my business, PheonixDocs, which focuses more on doctors' health and medical students' health, which I don't know if there's a lot out there at the moment. Um, and kind of, there's a lot of focus on patients' health, but not the healers themselves. So that's kind of what I want to give back.
Yeah, absolutely. I think it's definitely an underserved part of our healthcare, the actual
Yeah,
providers, and who's looking after the providers, and our future providers, of course, our medical
yeah.
students as well. It's something that definitely I think is certainly overlooked. So, do you see the general public as well, or are you focusing just solely on medical
Well,
practitioners?
I think starting out with this business, I'll definitely want to focus on medical practitioners. But and obviously with, I see patients part of the general public anyway, but I think I guess they're just trying to figure out how to tap into the market. Now, this actually stemmed from interest from medical students that I was teaching last year. So I was doing my usual tutorials with the university, but on the side, they kept asking me questions about food and nutrition and I guess for their own health as well. And so they kind of were the impetus for me to start this. So otherwise, I wouldn't have
Hmm.
even considered it really, because it seems like there is a gap, and that I feel like that gap has to be filled. Um,
Yeah, no, absolutely. So this, when did this kind of all start for you? And when did you kind of first get interested in the idea of the wider aspects of healthcare, like diet and nutrition and
yeah,
so on?
so it was 2019. I had just finished my GP specialty exams, and the 12 months leading up to those exams, I had gained like 10 kilos from
Mm,
the busyness of working full time, trying to navigate clinic medicine, moving away from the hospital. There's multiple factors there. So definitely wasn't moving as much. I was sitting at a desk, seeing patients. The stress of studying for these exams. So, and then convincing myself that I had zero time to cook. Um, I also was living on my own. So my boyfriend at the time, now husband, we were actually doing long distance. So no accountability, no one to check on me, was away from family. And I guess the cherry on top was the fact that I was living within a 5-minute drive of KFC, McDonald's, and Domino's Pizza.
hmm.
And, mix it all together, and you have and for myself, and probably borderline overweight, work like stressed out, burnt out general practitioner. Um, And so I feel like that was it. Something needed to change. I finished my exams and I was like, that's it. You know, something's got to change. I was very
Mm.
lethargic. I wanted to lose weight because the following year was when I was supposed to get married, and to fit into a wedding dress. So it was actually quite superficial, my goal, uh, rather than health, except get more energy at the time. And so I actually got the advice of going low carb from a colleague of mine at the practice that I was at. And she was very matter of fact. She said, "Oh, just go low carb." And I was like, "I don't know what those words mean. Can you explain that to me?" And she directed me to read The Obesity Code by Jason Fung, which
Right.
is a fantastic book. I don't know if you've read it yourself.
I I have. Yeah, it's a really good book
Yeah.
actually, and I think I spoke in one of my earlier episodes. But the patient that got me into this kind of really whole journey, he got me to read the obesity code. He brought
Yeah.
it in because I kind of refused to go
Yeah.
and buy it, and he brought it in, and it was like, right, you're
Yeah.
reading it, and he literally just bought it and brought it in for me, and I said, it's it's a gift, here you go, and I read it in like
Oh,
2 3 days.
same.
Yeah, and I just kind of couldn't put
Yeah,
it down.
exactly.
Yeah, and I was just like, yeah, okay, this guy's on
Yeah.
something.
So moving away from the whole calorie in, calorie out model to the hormonal model of obesity,
Mm,
like completely changed my practice. And it just made sense. So now, a bit of context, I actually have PCOS as well. Um, but at the time, I wasn't really making that connection. It came to me as I went through the motions. But I mean, I was diagnosed when I was 19. I was put on metformin by the specialist, took it for about 6 months, didn't really understand the implications of it as much back then, or maybe didn't want to, and then just forgot about it for about 7 or 8 years. So that was crucial for me to kind of realize that, oh, I need to eat this way because of this condition, because of my genetics, um, because of the fact that I later found out that I was insulin resistant with testing. Uh, this way, and it worked for me. I steadily lost weight, so I cut out all the snacks, stuck to main meals, was cutting out bread, pasta, rice, but more meat and more veg, and lost like 7 kilos or 8 kilos in like 12 months without like doing a ton of exercise. What's what everyone always talks about is, eat less, move more, which like doesn't always work. But other than that, it was actually again a combination of things. I'd finished my exams, I had more time to cook, I was less stressed, I was no longer doing long distance with my partner, so there was social accountability. I was no longer in an obesogenic environment where there was junk food all around me at all times. So I feel like it wasn't just one thing, but it was accumulation of kind of everything that kind of worked for me. And I feel like that's often forgotten somehow when we talk to people that talk about food and how it changed their life. Uh, that yes, it's a massive pillar, but it's not the only thing that matters. Like I've had patients who have amazing diets, very clean eating, they are getting enough protein, they're getting enough fat, all that sort of stuff, and yet they're not losing weight or whatever reason they've come in with. There's something not quite right, and I feel like we have to address all the pillars of health uh, for patients to get better, for us to get better.
okay, well, I guess that's actually a really good segue into lifestyle medicine, actually, because of course we talk about the 6 pillars of lifestyle medicine. Now, some of my viewers, listeners may know that I'm a certified lifestyle physician. So lifestyle medicine is really right up my alley there as well. But maybe, Melina, you could talk a little bit about lifestyle medicine and what it means and how it can maybe help patients.
Yeah, so basically, it's a way of practicing that looks at the patient as a whole, looks at their life beyond their symptoms, um, is one way that I'd put it. So we can have the conventional medical paradigm where a patient comes in with migraines, for example, and we will ask all the regular questions, all the red flag symptoms, make sure they don't need a scan, that it's not a tumor, and all that sort of stuff. And we could maybe give some basic advice in the conventional model in terms of do you have any triggers like chocolate or caffeine or whatever? And then that's probably the extent of it before we then talk about what medications have you tried? And here, try this. This might work. And we give them a medication treatment or a preventative one, depending on their frequency. And that's it. Whereas in lifestyle medicine and and integrative medicine, we go way beyond that. So we'll talk about, are you sleeping? Tell me about your stress levels. What do you do for work? Tell me about your typical day. What are you eating? Really kind of knuckling down on how do they live their lives. Um, they're going, if you talk about migraines in general, we know there's all sorts of triggers for migraines. Like I'll actually ask about their environment. So whether or not they have changed perfumes or are there has the partner changed his or her cologne or perfume or um, any new foods in the diet that might be a bit different. So there's more to it. I always think about things like magnesium and other micronutrient deficiencies that can drive things like migraines. So there's a bit more to the story, and it's just asking more questions. Now, obviously, it takes time, which not a lot of doctors have. Uh, just being seeing so many patients, especially in general practice. As a specialist, you probably do have a little bit more time, but mainly in primary care, we are very time poor, and probably in the emergency department as well. Although it's not always necessarily their fault because they're dealing with acute issues.
Mm.
So yeah, so I think that's probably one way of describing lifestyle medicine. So using migraines as an example, but any condition, any chronic condition, just
Mm.
going beyond the conventional pharmaceutical approach.
Yeah. No, absolutely. And that's certainly the way that I like to practice. And I've always liked to practice that way. And that's kind of how I fell into lifestyle medicine. I never knew it even had a
Yeah,
name. And I'd seen things like integrative medicine, functional medicine, nothing, they didn't quite seem to fit with what I wanted to do. And then I saw lifestyle medicine and that just, yeah, screamed at me. This is what I
yeah,
want to do. Although I don't follow every single aspect of it,
yeah.
but I obviously did the board certification and so on. So, but yeah, it's really about just really trying to delve into the root causes.
Oh, absolutely. That's
That's
it.
that's
Yeah,
really the bottom line, isn't it? And I think this is something that all doctors really want to do. I don't think anybody really wants to be practicing 6 minute medicine and in and out patients, just have a prescription, have a prescription, have a prescription, I don't think anyone really wants to work like that. But, the system we have here in Australia is unfortunately set up a little bit. And, the UK where I trained as well is set up to almost punishes long medicine, which is such a shame. It's an absolute travesty that we're just actively discouraged from spending time with our patients, which is
yeah.
just terrible.
I mean, I took
Um,
a I took a
I,
pay cut. So when I started talking to patients about food, this was in Townsville in a bulk billing GP clinic. I had
mm,
longer appointments because I wasn't going to rush through this. That was just pointless. Uh, and but it was okay for the time being. I was learning, and but even so, like I took a pay cut pretty significantly, but the rewards
mm,
that I got from patients getting better were way more than what I had expected. And I still to this day, I mean, practicing in Brisbane, yes, it's a mixed billing, more private billing clinic, but I'm still having longer appointments. I'm probably still making a lot less money than my colleagues in the same
mm.
practice who are doing 15-minute appointments. Um,
Yeah, yeah. It's a shame, isn't it, that the medical system we have here in Australia really does incentivize quick medicine.
Absolutely.
There's always going to be a role for that. Someone walks in, they've stubbed their toe. yeah, you don't have to spend half an hour or an hour with
Yep.
that patient talking about their diet and their
Yep.
lifestyle because of their
Yep.
stubbed toe. But then you've got people coming in with, I've got, rheumatoid arthritis, I've got type 2 diabetes, I've got high blood pressure, I've got high cholesterol, I've got metabolic syndrome, or you think they've got metabolic syndrome, they've got this funny rash that's bothering them, they're fatigued, they're tired, nothing seems to work, they want to lose weight. And you're like, yeah, okay, I've
Yeah.
got 15 minutes. Go. And it's like, yeah, no, that's
No.
never going to work, And you either have to just do these really piecemeal consultations or do these longer ones. But yeah, unfortunately, the system we have here really discourages that because you do take a big pay
You
cut.
do.
And I think that's something, or you just have to charge,
More.
what seemingly is a lot of
Yes.
money, to patients out
Yeah.
of pocket. Now, perhaps some of our American listeners won't necessarily understand what we're talking about, but I mean, they probably know about out of pocket costs over there, I'm
Yep.
sure. But yeah, here, obviously in Australia, the Medicare rebate pays substantially less the longer you spend with the patient. And it's the patient's rebate at the end of the day. So either they end up a lot out of pocket or the doctor ends up subsidizing, their care with their own income essentially, or it just leads to this, very quick consults, which is, really not a help to anybody particularly. You mentioned, of course, their nutritional deficiencies.
Yes.
And that's something certainly that I work with patients a lot with as well. What do you see is the most common mineral or nutrient deficiency that people
Yeah.
have?
So as a female GP, see a lot of women. So inevitably, actually really shocked to see the amount of iron deficiency out there especially in women, especially women of reproductive age. It You ask anyone at my clinic, and everyone's shocked at how many patients keep coming back for blood tests, checking their iron, not working. We do everything else, and they end up needing an infusion. It's insane. It's like every week, and I don't work every day. I work 2 or 3 days a week in a clinic, and every week I end up having to do an infusion in at least one patient, which is baffling. But other than that, there's zinc, which 70 to 80% of my patients are deficient in. Magnesium, a bit tricky to pick up on blood tests unless you do like red cell magnesiums, and I don't do that often. But I still look at the range of even a serum one, and I've picked up frank deficiencies like outside of that range. Um, but even from the stories you hear, the symptoms for all of these micronutrients, like I'll suspect and I'll literally have the tests confirm my suspicions, either iron or zinc or magnesium or B12 or omega-3, although I don't do testing that much on omega-3. But again, from the story and from the physical
Mm,
exam, you can tell. Vitamin D is the other one. I
mm.
could keep going. Like, there's so many.
Yeah, no, definitely. I mean, I see it a lot in the practice that that I do as well. And so, yeah, interestingly, vitamin D or vitamin D. I've started calling it vitamin now. I think I've been in Australia here long enough to start saying
Yep.
vitamin at times. I caught myself saying it for the first time the other day. Vitamin. Well, hang on.
Yeah.
Yeah,
Yeah.
maybe vitamin,
You're
vitamin. Anyway,
morphing.
a sign I'm morphing into
Yes.
an Australian. Absolutely. And yeah, it's funny because I mean, I work here in Queensland. You live in Queensland as well. We're called the Sunshine State.
Yes.
Yeah, vitamin D deficiency is so
Yes.
common here.
Absolutely.
It really is so common, and yet Medicare, won't let us test for it in most people. Yeah, absolutely
Yeah.
crazy. Um, but I mean, I figure it's because, actually outside of work hours, people don't get that much sun.
No, well, it's either too hot, um, or they might get maybe 5 minutes at lunch, which I think's great, but that's so far and few between. Like they might, I've got patients who will just grab their lunch, but have a takeaway lunch and then walk 2 minutes in the sun back to their office and eat at their desk. So, or it's shift work. A lot of shift workers, us doctors included, have the worst levels of vitamin D. because we literally don't get out at all.
Yeah, no, I think the lowest levels I've probably seen in people are probably
Yeah,
nurses,
not
actually,
surprising.
because they're just, yeah, they're shift working all the time. They're stuck in the
Yeah,
hospital all day. And although, of course, we live in the sunshine state, it's really only sunny between about what, roughly 6 and 6. Outside of that, there's almost no sun. Any time of the year, almost. It varies by what, an hour maybe. So people are working and they're not seeing the sun, or if they're shift working, they're working at night, they're in bed in the day. So they're just not getting it. And vitamin D deficiency, I think people don't understand how important vitamin D actually is. And it's a pro hormone, and
yeah,
it's just so important for our hormones. Of course, you mentioned polycystic
yeah,
ovarian syndrome earlier.
absolutely.
I see a lot of
Yeah,
men as a male GP. I see a
yeah.
lot of women with PCOS as well. A lot that don't even know they have
Oh, yeah.
PCOS.
But interestingly, it's hard because a lot of women don't realize they have PCOS because they're on contraception for so long, on hormonal contraception for so long. And I was fortunate in that I was only on contraception maybe for like a couple of months before I got the diagnosis. And a lot of it was on my history, rather than ultrasound and things. But I think our hormones as women are so altered, especially in younger years, by hormonal contraception that we don't even know what's normal anymore. And there has been a shift with maybe younger women, from what I've seen, that want to come off hormonal contraception and kind of see what their cycles are doing, uh, knowing full well in terms of pregnancy risks and all that sort of stuff. But it's this, it, I mean, it's been called a vital sign. The fact that if you're getting an ovulatory period once a month, it's as important as a blood pressure or a temperature or a heart rate, because it's almost
Mm,
as if your body's saying, okay, we're safe, we're okay, we can have a baby. And how complex that whole process is. And often with modern day lifestyles, with stress, with trauma, we lose the ability to ovulate because our body says it's not safe to have a baby. So I think it's actually quite powerful as a woman to know if you're ovulating, and the fact that you're having a regular cycle. I'm not saying contraception is bad for everyone, but there are pros and cons. And more often than not, I see a lot of women that have lots of side effects from contraception. So it's a give and take, and you got to assess
mm.
each individual situation. But yeah, you're right. Not a lot of women even know they've got PCOS.
Yeah, and that's kind of sad in its own right, really, that a lot of women don't understand. They don't know that their cycles are a vital part of their health. They don't know that what they've got is not the norm. I don't like to use the word normal very often, but because what is normal. But I use the word
Yeah.
common a lot in consults. But yeah, a lot of women, they come in saying, "Well, isn't that just what everyone has?"
Yeah. How weird.
Even I know, like, I just think we don't talk about menstrual health anywhere near
No.
enough. And especially, as doctors, I think, and I'm sure men probably could be talking about it a lot more than they do
Yeah.
as well. But even women, I think maybe just don't talk about it enough. Endometriosis is another really good example. That do you see many women with
Yeah.
endometriosis?
To varying degrees. So obviously a lot of these conditions, there's a spectrum to them. So from my reading and all the gynecologists I've spoken to, they say most women have some form of endometriosis, so endometrios, like endometrial lesions, but it's whether or not it manifests, how severe it is, and so there is that kind of spectrum. So really, really interesting. Does that mean every woman needs a laparoscopy to diagnose it? Not necessarily. I myself might have had it. I was offered a laparoscopy, and I opted out of it and wanted to, because it wasn't as severe. I wasn't, missing school or work or anything like that. Uh, but I was in pain, and I opted to kind of figure out alternative options. to manage the endometriosis. So I had a Mirena IUD inserted for a bit, didn't quite agree with me, got off of it, and really just kind of focused on lifestyle, nutrition, supplementation, stress reduction, and very fortunately, I mean, I've never thought I would say this. If you ask my 16, 17-year-old self if I could have regular cycles and not be in pain and not be super heavy, like she'd be falling over laughing because that's just not possible in her mind. But I'm very, very lucky. I think the work that I've done on myself, I don't want to jinx it, but yeah, I'm quite excited with what's possible. And I feel like women don't know that you can have a normal cycle with no pain and it not be super heavy and not have as much PMS and it be absolutely fine.
Yeah, I mean, what kind of things do you do to help women then with conditions like PCOS and endometriosis? Because you're obviously working towards your fellowship in lifestyle medicine. You're working towards your fellowship with acne. You got work in integrative, medicine
Yeah.
as well. What are some of these other perhaps non pharmacological ways of helping women treat these kinds of conditions?
Yeah, so I guess it depends on what they're wanting. So, in terms of their goals, so it's always important to ask when they're coming in. I've had a couple of women, early 20s, n- newer diagnoses of PCOS, but not quite getting the satisfaction from other doctors in terms of what they're wanting. So I've had some patients come in, they don't want contraception, they're not necessarily that sexually active. They want to see what their cycles are doing, but it's really irregular. So every couple of months, maybe once or twice a year. Uh, and you then start doing testing. And like I said, 70% of women are with PCOS are insulin resistant, if not pre diabetic or diabetic. And so he's literally, again, comes back to the pillars of health with every chronic condition. So look at their sleep, look at their stress, look at their food. Are they moving? What kind of job do they do? Do they have social connections? Or do they have a purpose in life, which is huge? Um, what are their relationships like? What's their environment like? So, uh, obviously, from a nutritional perspective, it is going to be a lower carb lifestyle. I say lower because there's a whole spectrum of what it means to be low carb. And so everyone's different in terms of how much carbohydrates they can tolerate. But I am pretty aggressive initially, which patients are happy with. They're willing to go all in because they know what it means to have regular cycles after I tell them about it. Um, and I get results. So lower carb, less processed foods, keep it simple, some form of animal protein, some sort of vegetables. If you want to have a bit of fruit, that's fine, but keep an eye on it because fruit's got lots of sugar in it. Make sure you're getting healthy fats. Make sure you're getting enough protein. A lot of people, not just women, even men, don't eat enough protein.
For sure, for sure. So many people are just, I mean, medically not protein deficient,
Yes, but not optimal.
but they don't, but definitely
Yeah,
suboptimal. Absolutely, and I've heard this criticism, from people saying, oh, it's not like people have kwashiorkor, which for anyone out there, it doesn't know what kwashiorkor is. It's a severe kind of protein deficiency, very rarely seen nowadays, other than in developing parts of the world. And it's a severe protein deficiency. And they say, oh well, these people aren't getting kwashiorkor, they're not getting beriberi, and all these other really serious, protein deficiencies. Things you read out, things you read about in textbooks and so forth, and never see in
yeah.
real life. But they're definitely still protein deficient.
Yes, and it's so nice to see patients coming back and telling me since they haven't really done any of the other things that we've spoken about, maybe they haven't really taken the supplements, which I correct their deficiencies and things like that as well. But I've had patients who've literally increased their protein and really not done much else, which indirectly actually helps them get the nutrients that they're deficient in because a lot of animal protein has more bioavailable micronutrients like iron and zinc and B12. And they come back and they tell me I've got more energy, I'm not as hungry, I'm sleeping better, my mood's better. Like it's so
Yep.
basic.
Yeah. And it just snowballs,
You sleep
doesn't
better,
it?
you make better food choices, you've got more energy, you can exercise a bit more, your relationships with your family is a bit better because you're not snapping at them from sleep deprivation.
Yeah.
Yeah, it's actually quite nice. But yeah, I mean, I like you were asking how do you manage it, like PCOS, for example, but food, supplementation, exercise. I really talk about if you're insulin resistant, PCOS or not, or pre-diabetic or diabetic, resistance training is key. A lot of patients are usually do a lot of exercise anyway. The young patients that I see, they're already like, doing cardio and swimming and cycling and all that sort of stuff, but not actually lifting weights, which we know building muscle. Muscle is one of the biggest glucose disposal organs out there. And so if you've got a higher amount of muscle mass, even from a younger age, your body can handle carbohydrates and therefore not
Mm.
need as much insulin to work as hard. So I feel like sometimes that's missing for some people, although I think it's starting to come a little bit more. But yeah, it's still worth emphasizing. But you have to ask these questions. That's the thing. And if you don't ask these questions, you're never going to know. And I feel like, unfortunately, again, being time poor, not learning as a medical professional, not knowing to ask these questions on a routine basis, uh, it, it's unfortunate, but we kind of miss the stories of our patients' lives in some ways as a result of that, which can often, in some cases, be make or break in terms of them getting better. Because patients will say,
Mm.
"Oh, they never asked, therefore I never said."
Yeah. It's certainly a common story. And again, it comes back to being time poor. Yeah, I mean, weights are something that is so important, and it's something that's so misunderstood with weight training. People often think weight training, muscles are just for vanity. They're really not. Muscle is so important. Skeletal muscle is so important. And now I can't remember the exact statistic, but we know, evidence wise, and I say this to all my patients, but particularly when they're starting to get a little bit older, um, your muscle mass is really directly proportional to your ability, your likelihood, sorry, to go into a nursing home,
Not
or
surprising.
inversely
Yeah. Yep.
proportional. There's certainly a relationship there, whether it's 100% correlated or not. There's definitely a relationship there, and if it's to the point where you can't get off the
Yep.
chair, by
Yep.
yourself without using your hands, you're in a pretty bad way
Yeah. Yeah,
already.
absolutely. Or if you have a fall and you can't get back up again, proximal
Yeah,
muscle strength.
absolutely. Muscles are so important, and getting moving is always good, but lifting weights or moving weights, resistance training of any kind is so important. It's so good to hear you say that. That's something I really just try and drill home to my patients, because nobody, well, some people like doing
Yep.
cardio. Yeah, some people do. A lot of people don't.
Yeah. Yeah. That's fair. I don't.
Yeah, I don't. I hate
Yeah.
it. And if it, when you start to say people, oh, you have to exercise, you can almost see the eyes just glaze
Yeah.
over.
Yeah. It's got
And
a
and
very
and then us,
negative
yeah.
connotation, the word exercise. I've been trying to use the word movement a bit more instead with patients. I don't ask, do you exercise? I ask, do you move? Which often I feel like language can be quite powerful, and patients are more likely to talk about different types of movement with the word move rather than exercise. I'm all for like incidental exercise and movement. I mean, I do it myself. Like I'll walk to supermarket. I won't push a trolley. I'll carry a basket, and I'll actually do random like bicep curls and things with my heavy basket. I can just make sure no one's in the aisle, and I'll just do a couple of like tricep dips and things. But so I'm like, if you're busy, if you're that busy and you don't have time to like go to the gym or, all that sort of stuff, there's lots of barriers for people to move and exercise. I'm like, well, just build it into your day. Isn't that how we used to move as humans? Rather than go to a gym, that didn't even exist
Absolutely.
back then.
Absolutely. We didn't have gyms, thousands of years ago, and so on. Modern man is very different to what we used to be. But that's a really good point. Is trying to find a way to make it work in that patient's life. That's the thing. There's no point me saying to people, you saying to people, go and exercise for an hour. And they're like, but I've got, 2, 3 kids. I've got a, full-time job. I'm working 2 jobs. My partner works. I've got to look after my parents. And what time do I really have? And yes, we all know we've got at least 5, 10 minutes here and there. But to that patient, the perception is they don't. And so you've got to try and find a way, I think, to get them to work it in a more natural way. And even, just things like standing. Like I'm standing at the moment,
Yes.
because it's so much nicer than
Yes.
sitting down. I
I
don't know if
am
you're
sitting
standing or
down.
sitting, but um, but for a long time, I've had back
Yeah.
issues, probably from years of playing hockey and being overweight, and so I prefer to just stand now. But yeah, it's so much better for me to do that. And these are little ways that I try and manage. In between patients, I just do like 10 squats,
Oh,
just my
so
own body
do
weight.
I.
You know,
Yep.
just between patients, like lunchtime, I might just do some push-ups on the floor in my
Yes.
office. Yeah, anyone that opens the door is going to be like, "What
Yeah.
the hell are you
Yeah.
doing?" But that it's just a way that I can get some exercise in through the
Yeah.
day, in case I struggle when I get home. 3 kids, busy life.
Yeah.
Yeah,
Yeah.
you gotta find a
If
way,
I'm
haven't you?
heating up my food in the microwave for lunch, I'll do 2 minutes of squats while the food's heating up.
Yeah.
That is hard, by the way. Yeah.
Oh yeah. 2 minutes
Yeah.
is hard.
Yeah.
Oh
So
yeah. Yeah.
but yeah, I'm like, what else would I be doing in those 2 minutes? I don't know, scrolling on my phone or chatting to someone. Like, it's 2 minutes that's,
That's it.
could be used to move. I don't know if, like, I don't
Yeah.
know if it's gonna work. I don't know if other GPs do it, but I would love to have a standing desk and do consults with patients standing up.
Yeah.
I just don't know how that would work.
Yeah.
Obviously, I have the option of sitting down if the patient wants to sit down, but I've just thought about these
Yeah.
things, like, to increase my own movement.
Yeah, I've often thought about that, and I know some doctors
Yeah,
do, and you see reports that patients love it, and I'm not sure patients
love
love
it,
it.
yeah.
Yeah, that might be a bit strong. I don't know. Oh, I've got to stand up for 20 minutes now. Okay, but it's something that I would love to do, but yeah, the clinics that I'm
Yeah,
at, it's all just fixed
fixed, yeah,
fixed desks. The chairs aren't the right height, the desk is the
yeah,
wrong height, the keyboard's the
yeah, yeah,
wrong
yeah,
height, and you're like, that's me trying to talk to people about posture and
yeah,
ergonomics and
yeah.
all the rest of it, and I'm
Do you
stooped
find yourself,
over, and
like,
yeah,
sitting up when you talk about posture? I feel like I'm actually, like
a little bit. I'm pretty conscious of trying to sit
yeah,
properly anyway,
because of your
because
back.
otherwise I get issues with my back and stuff. But yeah, I still find myself just stooping over, and the chair I've got at one of my clinics, it just kind of like sinks through the
Oh,
day.
yes, it's one of those.
And so when, I don't realize, I'm like, hang on, I'm like a foot lower than the desk here.
Yeah.
What's going on? I have to sit myself back up. Yeah, I mean, movement is so
Mm.
important, and finding a way for people to just get it in
Oh,
to
yeah.
the day here and there is really a
Yeah.
good idea. Now we've spoken a lot about quite a bit about PCOS, and endometriosis, and there's probably hopefully some men out there listening to this and taking this on board as well, but thinking, okay, well, what about testosterone? What about andropause? Is this something that you have seen much of yourself with male patients?
So, I haven't had a lot of male patients yet. But I have had, family members. So the woman comes to see me, then she brings her husband and, her son, and that's kind of how it's working. Um, some men I see that are younger, because their age is in their favor. So testosterone, so far, in the early 20s is working for them. But older men, the moment you see show signs of metabolic syndrome, like, I know your testosterone's not that great. I feel like it can go both ways. But I don't
Mm,
routinely test testosterone. I know I probably could, but I just haven't had the patient demographic to experiment with that too much. Uh,
mhm,
but in general, if you think about the implications of low testosterone in terms of their well-being in men, um, like hands down, most of the time they're on the spectrum of having metabolic issues. As kind
mm,
of like the dominating presenting issues. Mood might be another one, and sleep. And often the men that have come to see me, for example, that will say, "Oh, my libido's on the lower side." They're not sleeping.
mhm,
Uh, and we know our hormones are much better regulated at night when we sleep. And it was simply a matter of correcting that and maybe having a bit more protein. That often can turn things around, other than obviously addressing any psychological issues with low libido and things like that. But yeah, I mean, from what I've seen. I haven't routinely tested for testosterone, but often, again, you go back
mm.
to the basics, and you can kind of pick up on things that will correct. Our body is pretty remarkable that way. The one thing I do know, which I think just needs to be emphasized, is that the modern day lifestyle was not designed for the human body.
Mm,
So no wonder we're seeing massive chronic disease burdens that are just escalating exponentially at the moment, all around the world. Is because we were not designed to live this way. And once you unpack that for an individual patient and what that means for them, that's it. You're getting to the root cause.
yeah, this is huge. I mean, we're not. We're just really not designed to live the way that we live nowadays. Working 24/7, eating 24/7. Barely sleeping, no social relationships. Drugs, alcohol. Substances. Fake
Yep.
foods, and all of this
Yep.
stuff. Yeah, it's totally unnatural, and the human body just wasn't designed to deal with that, and that's why we see the issues I think we see nowadays.
Mm.
Yeah, I mean, for any men that out there that are listening, I mean, I do a lot of work with men. I see a lot of male clients, male patients, and I mean, it's basically exactly the same as PCOS.
Mm. Yeah.
Pretty much. It's just this metabolic syndrome, this hormonal metabolic
Yep.
syndrome. It's simply usually low testosterone versus or low relative estrogen, typically in PCOS. And it's the same. It's the same reasons often, and it's the same fix. It's going back to those basics. Looking at your diet. Very often, a low carbohydrate approach can
Yes.
help. Studies show. I read one study that suggested a low calorie ketogenic diet improved men's testosterone by up to 10 times,
Wow.
which is like that's
That's
insane.
huge.
That's just
I
absolutely
wonder if it's
insane.
the fat. It said
10
ketogenic, so I
times.
wonder if but it's low calories. How does it work
It
with the fat?
Yeah, well, it's interesting because this study they looked at a
Yeah.
ketogenic diet, and they looked at a low calorie
Yeah.
ketogenic diet, and the ketogenic diet increased it by up to 3 times. I think the average, with median was something like 1.5, 150
Yeah.
percent roughly. And then the median in the low calorie group was the low calorie keto group was I think about 3.5 to
Yeah.
4
Right.
times, but potentially up to the confidence interval
Yeah.
went up to 10. So it sounds more impressive when you
Up
say
to
up up
10.
up to 10 times. It sounds more impressive, but that's perhaps slightly misrepresenting
Yeah.
the facts. But yeah, interestingly, that the low calorie group did increase more
Mm.
than the non calorie restricted. Now, I'm not sure exactly what the mechanism is
Yeah.
there, why that improved so much, but it's very very interesting. Observation, and of course things like zinc
Yep.
deficiency, we know, big driver towards
Oh,
testosterone
absolutely. Yep.
deficiency. Zinc supplementation can improve it by potentially around 300%, so
Yes.
around 3 times in
Yep.
studies have shown.
It's actually in so
More
zinc
sleep.
is in often male fertility supplements,
Absolutely.
which is,
Yeah,
yeah, just often forgotten.
absolutely. Zinc is so
Oh, yeah.
powerful.
Absolutely.
And yeah, and like you said about You said about what 70-80% of patients that you test are zinc
Mm.
deficient. I think,
Adult
yeah, I
patients,
was
but probably some
adult.
kids as well, from what I can
Yeah,
assume.
it's probably somewhere north of that for me. I think maybe like 90%, maybe 95
Mm.
even. Like it's so high. And it's estimated to be one of the most, if not the most common deficiency, I think, in the world nowadays, along with magnesium is very, very, very high as well. Particularly here in Australia, we have, I think, pretty poor soil quality, and that's, I think, the main reason why we maybe have these
Yeah.
deficiencies here. But even across the
Yes.
world,
But also, I think if you think about
um,
magnesium and other than the soil, what are the other causes? So I tell my patients, if you're drinking alcohol, if you're drinking caffeine, if you're having processed foods and you're
mm,
stressed, which is, most people would fall into that category in the modern day lifestyle. And
yep.
probably 90 to 100% of medical students and doctors.
Yeah, probably. I mean, I certainly used to live. I lived on about 6 cups of
Yeah.
coffee a day, I think, prior to my current lifestyle. So that's probably why I was
Yeah.
magnesium deficient, most likely. But yeah, it's a very common cause of magnesium deficiency. Is caffeine
Yes.
excess. So yeah, so for men listening out there, testosterone deficiency certainly can happen. This metabolic syndrome can definitely
Mm.
happen. But the fixes are pretty easy
Mm.
actually, and
Yeah.
profound. The symptoms that some men can get are really are profound, and it really can affect them. And it's very interesting that at least anecdotally, myself, a lot of probably most, if not all, of the men that I test for testosterone deficiency, when they have a mental health condition, almost invariably come back low testosterone,
Ah, interesting.
which is very interesting. And we know that a low testosterone is linked to more
Yes.
suicidality in depressed
Yes.
young men, by potentially up to two
Yeah.
times, 200% increased risk, which is
Yeah.
enormous. As is a low cholesterol,
Yeah.
a
Yeah.
low LDL.
So is
Interestingly,
that the lower
um,
end of the range, or is it actual frank
I
deficiency?
think that's actual
Yeah,
frank
wow. Yeah.
deficiency. But yeah, even the reference ranges. I mean, not a lot of people know how
Oh,
reference ranges even
yes.
work.
That's like a whole nother
And
thing I can talk.
yeah, I mean, and I see, and it's a shame, really. I see some doctors, looking at results and they're just ticking normal,
Yes.
no action, normal, because it looks like it's within the
Yes.
reference range, but it's actually a totally abnormal result.
Yeah. I agree.
But it's in the
Yep.
reference range, and then and I've spoken to some doctors about it before, and they've said, yeah, but it's in the reference range,
Mm.
and I've said, but don't you understand how reference ranges
Yeah, it's a
work?
population-based assessment,
Yeah,
and
it's like the first 2,000 people that go in, and
yeah.
if the first 2,000 people are going in are deficient, well, the ranges are going to be low.
Yep.
That's the thing, and testosterone's a really good example of
Yeah.
this. The average testosterone level has fallen by about 50% in the last 50 years. Yeah, it's huge. It's massive. It's absolutely crazy, and no one's talking about it. And in this society we have nowadays of this kind of idea that testosterone's bad and we need to lower testosterone, and so on. Actually, it's quite the opposite. When you improve men's testosterone on the whole, you tend to find that they become more not docile, that's not the word, but just more
Mm.
calm, more collected. They become less aggressive, less angry, less anxious, less
Mm.
depressed, more sure of themselves, more confident, more
Yes.
motivated. Which is really, really interesting. I had one patient recently, actually, this who just really embodies this, saying that I'd worked with them to increase their testosterone, and they came back and said, "I feel like I just want to be a better man."
Yeah.
And yeah, and he just said, "Yeah, I want to just like do things at home and be more manly." And to him, that masculine meant providing and
Yes.
supporting and nurturing his
Mm.
family and building that safe home,
Mm.
cleaning and cooking
Yep.
and ironing and the dishes, and he was like, "Yeah, this is like weird."
Yeah.
But like in a really good
That's
way.
great.
And that's personally what I found when my testosterone went up with my carnivore
Yes.
diet. I found exactly the same. I just wanted to cook, to clean, to iron, to do the washing, and my wife was like,
Yeah.
"Hey, this is great."
Yeah, I'm trying to convince my husband to try carnivore a little bit.
Yeah, it's I mean, that's maybe that's a good segue then into what your diet's like. What exactly are you doing with your diet at the moment? Because we haven't
Yeah,
touched on
yeah.
that yet.
So I'm still low carb. So this is it started 2019. So yeah, a couple of years into it now. Obviously to varying degrees throughout that time. But I've never gone back to what I was having before, massive amounts of bread and rice and you know, granola bars and all sorts of other things in terms of high carbohydrate processed foods. So that's occasionally might have experiment with a bit of low carb bread just to see what that tastes like, so I can tell my patients about it if they're really desperate to have bread. Um, but yeah, so relatively low carb. I have had days where I would classify my meals as maybe keto, not by
Hmm.
measuring, but just you look at what's on my plate and there really isn't much carbohydrates there at all. So it'll literally just be like meat and salad for dinners. I meal prep once a week, which really helps. So at least for the lunches for my husband and myself. So just batch cook like curries where I just throw like a bit of vegetables in just to get a bit of color in. Or chilies are really actually really really nice. So I get my red meat through mince quite consistently, other than my dinners. And I am oddly proud of this, but my ferritin is high 60s without supplementation,
Mm,
which you don't see that in a lot of women of reproductive age that bleed every month. Um,
yeah, no.
so now, when I talk about red meat, I'm ideally wanting myself, my husband, and everyone I tell to have good quality grass fed red meat. Um, so that's I think, and just animal protein in general, the best quality you can afford, uh, because standardized grain fed cattle has inflammation in and of itself. So that marbling that you see on really nice marbling that you see on cuts of steak, the good wagyu and all that sort of stuff, that's actually metabolic syndrome in cattle,
Yeah.
unfortunately.
Yeah, I think that's something that people don't actually understand, and I see people talking about it on carnivore forums and so on, saying, "Oh, well, surely we want, if we want the fat, surely we want to eat grain fed because they're fatter."
Mm,
But I think they're misinterpreting it, as because yeah, it's basically that cow essentially had metabolic syndrome.
yes, from the grain.
It, yeah, from the grain, and if it's not good enough, for us, why are we then wanting our meat, our food
Mm,
to eat that? We are what we
yes,
eat, and we are what we eat has eaten.
yes, yeah, absolutely.
And it, yeah, and if we don't want to eat grains, we shouldn't be expecting our food to eat
Right.
grains.
Um, the tricky part there is finances for a lot of people. So unfortunately, we know grass-fed meat
Mm,
tends to be a bit more expensive. I have figured out a couple of ways around that. Obviously, going to butchers generally a bit cheaper. And if you don't go to the butchers or don't have access to the butchers, and all you have access to Coles or Woolworths or the other main supermarket chains in Australia, see if you can get them when they're on sale. It's a nice tip that I tell my patients. And I've told my medical students as well, who are always on budgets. If you can get them on sale, if you've got access to a freezer, if they are going to expire in the next couple of days, just freeze them. And that way, you're saving a bit of money. It's a little bit healthier. But, if you can't, you can't. Like, and that's okay. Um, it's not just about
mm,
red meat. There are other sources of animal protein. There's chicken, there's eggs, there's fish. So, but unfortunately, those sources will not get you your iron as much as red meat will.
as much, yeah,
Yep.
absolutely. So you're doing low carb
Yeah,
yourself. You're not tempted to go into
carnivore.
the carnivore
Yeah,
world at
so
all?
I was hearing kind of going down a bit of a rabbit hole, I think end of last year, a little bit with it. And I was like, oh, maybe I should try. And unfortunately, it was the worst time to try because it was Christmas. So my before we went to see our family for Christmas, it was about a week or two that my husband and I attempted carnivore. And by that, basically not having salads with our dinners as a starting point, or having the tiniest amounts, basically. But that was hard, I think. We have definitely increased our protein intake, so I think that was easy. But I think unlearning a lot of that, very, very tricky. And it wasn't
Mm.
as pure. So obviously it wasn't no vegetables. We were also still both having coffee, um, which I know you've gone off of completely, and you feel like you don't
Correct.
need
Yeah.
it. Uh, but
Mm.
yeah, we were a bit too attached to the coffee.
Oh, look, I think everyone's got to find their own rhythm,
Yeah, yeah,
with it. Everyone's got to find their own way.
yeah,
Certainly, I don't push on anyone. What I do. I think everyone's got to find what works for them and find what makes them feel good, and what doesn't make them feel good. And I think when you start to chip away a lot of those processed foods, ultra hyper palatable, sugary foods, and so on, you start to learn those signals again. And that's what I found with low carb, with keto, with intermittent fasting, and now even more so with carnivore. You start to learn what your body wants, what it doesn't want. You learn those signals again, and then you can just work it out so much easier. What actually makes me feel good? What makes me feel bad? And then you just go from there. You certainly don't have to do like a pure carnivore. And I know there's probably carnivores out there listening to this podcast going, "Oh my god, he's saying you can drink coffee and eat fruit and whatever."
yeah.
And I think there's a lot of divisiveness when it comes to this in the carnivore
Mm,
community. I think everyone's just got to find what works for them, not what works for other people. That that for me is the key thing. I do think that we are all one human species, and we all should have a one optimal diet, but everybody has their own illnesses, diseases, conditions, and tolerances. And everyone leads a slightly different life, and they're maybe more physically active, or they sleep longer, or they work more stressful job, or everyone's a little bit different. So everyone's got to find really, I think, what works
yeah,
for them
absolutely. Yeah,
ultimately.
I have
Yeah.
tried to recommend carnivore to a couple of patients in the last few months, mainly as a reset. So, in terms of gut rest, in terms of breaking sugar cravings. So, like, I've had one woman who was just yo-yoing with her weight for years. And, I spoke to her about low carb. She tried it, things were getting in the way, weight crept up, became pre-diabetic, and I was like, you know what? She was desperate, which I think is really interesting. If you can understand a patient's level of desperation, it's almost like you might even get better results because they're willing to go all in. And so
Mhm.
she and I told her, I was like, 2 weeks, only animal protein, that's it. And it took
Mhm.
her a while to mentally adjust to that sentence. Um, and she was like, can I have green vegetables? And I was like, if you want, you can have green vegetables, that's fine. But she came back 2 weeks later and I was like, did you have the green vegetables? And she was like, no, I didn't need it. And she felt great. So,
Okay.
so the main thing for her was to break the sugar cravings, to completely reset her cycle with her awareness, her signals, her appetite, uh, leptin, ghrelin, insulin. So, and it was after that point that we started slowly reintroduce. She wanted to stay low carb, so she wanted to have vegetables, and you got to meet the patient where they're at. And I'm like, cool, let's do it, but let's do it in
Mhm.
a staged process. again, this was through Christmas and New Year's. So very tricky time to
Mm,
be doing this, but she pulled through pretty well. Um,
mm,
and she felt a lot better. Like for the first time, she was saying that she's a mom of one, and she stopped working to raise her, and she was thinking about actually doing things for herself for the first time in over 10 years. And I don't know whether or
mm.
not it was because she was eating differently and something changed in her brain, uh, or it was just coincidence, but it's almost as if like the fog lifted a little bit and she could envision a future of doing things for herself versus just
Yeah.
being a mom or just being a wife, which I thought was quite cool. Um,
Yeah, that's a really interesting story, actually, and good for her that she just kind of took your advice and just trusted you enough to just kind of go for it. And yeah, it seems alien.
yeah,
Um, as a doctor myself, it took me um, a while to come around to the idea. And I spoke before in my podcast about my journey into carnivore was, yeah, probably about a year long,
yeah,
actually, if not
yeah,
longer, of just kind of like denial and saying, this patient that got me into it was just going to kill himself on carnivore and so on. And then I heard Dr. Anthony Chafee,
yes,
Plant Free MD,
yeah. I
speak,
heard him speak too.
um, and Low Carb Down Under, and that was just like, yeah, okay, I'll try it.
Yeah,
Why not? And then I just haven't looked back since. But it can be hard for some people to get started because it's such a
yeah,
paradigm shift. It's such a mindset change of, you don't have to eat these
mm,
vegetables, and in fact you may not want to
yeah,
eat these vegetables. You shouldn't be eating these vegetables, and that's what the carnivores would say. um and then and that's it's such a change for them. It's
it is
hard,
hard. It's
and people
it's
wrestle with it.
unlearning everything you were
Yeah,
taught, even from when you were a kid.
that's it. That's it. And it's funny because people will take out the sugar, they'll take
Yeah,
out the sweets, they'll take out the
yeah,
chocolate, they'll take out the alcohol, they'll take out the smokes before they'll take out the vegetables.
yes,
And these are the things that they don't even like most of the time,
yes,
and they still won't take them out. And it is kind of funny. Sometimes they'll just go for it, they'll
yeah,
trust you, and then they see the positive results, and then yeah. And that's what I do with patients. I try and use it as almost like an elimination diet,
yes,
or as a reset, as you said. Go back to
yes,
basics, relearn all those signals, and then if you want
yes,
to, carry on. If you don't, move forwards and just work out what it is that you can eat that doesn't, really cause you
yeah.
an issue. And that can work really, really well for that. So what does your husband think of your low carb, diet, and trying to push him onto carnivore? I assume he's somewhat
Oh,
agreeable as he
yes.
tried carnivore for a week as well.
So he's he thinks I'm coming into this field a bit late, especially with the whole protein thing. So he knew about the importance of protein because he used to go to the gym a lot when he was younger, when he was in end of high school and university. So he was already on top of the whole protein thing. Um, so I'm the one that's late. But I think, yeah, definitely on board with low carb, understands the principles of it, just makes sense. So I don't know if I've mentioned it, but so he is a doctor as well. Um, yeah,
Okay, yeah, no, I didn't
so
mention that. Yeah.
he's dual training ICU anesthetics, which brings its own stresses, not just one training
Mm,
program, but two. Um, and so uh, what we've learned, both of us, with our journeys into medicine is in the last couple of years, like we need to be really consistent with our eating habits uh, because of the stress that's coming our way, left, right, and center with our jobs and our training. So, eating and sleeping and movement, like consistent. And recently, we're trying to get into meditation as well. But he's totally on board.
mm,
He's happy for me to like do all the grocery shopping, plan all the meals. Like, and I don't mind. I'm happy to do that. But he like puts complete trust in me, which I appreciate because it's just easier that way.
Mm,
And in terms of him going carnivore, yeah, I don't know. I don't know if we might try it again this year. I'm not sure. But I think if we keep thinking about the human race and how it was a bit of an ebb and flow of what was available at the time, depending on where you lived and the seasons and the weather and all that sort of stuff. And so we're kind of tossing up with the idea of yes, we hunted and we ate a lot of meat, but we also had a bit of, plant foods here and there where it was available. And we fasted when there
mm,
was no food available. And so I feel like he and I were kind of in that space of somewhere in between, but more animal protein dominant for the time being. Um,
mm,
but I think it's hard. And I see this in a lot of patients, like where the woman comes to me and she's the one in charge of the household, and we're telling her to eat one way, and yet she has to make meals for her partner, for her kids, and she gets sick of making three different meals, and that's what like makes her go off the wagon, as they say.
mm.
So very fortunate that I've got uh, the other person living with me in this household on board with what I'm eating.
Yeah.
So it's just so much easier.
Oh yeah, for sure. It makes a huge difference, and I see that as well. One of the biggest barriers to people changing their diet is, unfortunately, their
Yeah.
family. A lot of the time, I mean, we talk about social determinants of health, of course, very very real. People talk about the finances as a big issue, and it is for sure. And we spoke a little bit earlier about the finances on for
Mm,
red meat. But a lot of what I see is the social relationships,
yes.
um, and that is a barrier. Exactly like you said, it's people trying to do better, and then their partners, spouses, kids, whatever, making it
Mm,
difficult for them, either unintentionally or sometimes
mm,
intentionally. I spoke to a patient recently. Unfortunately, she was really trying to do better, but every time she would make a meal, her husband would basically sabotage it,
mm,
and say like, why aren't you eating these potatoes? I bought these potatoes just for you, and I bought this bread just for you, and I made this bread, and look, I've made you a sandwich. You need to eat
that's
it, and,
tough.
and all this kind of stuff. Knowing that she's trying
Yeah.
to do a
Yeah.
low carb, to the point where I basically gave her a medical certificate and said, she must eat low carb, and then she gave that to her husband,
Yeah.
and then the husband basically
Oh,
backed off,
thank goodness for that.
which is just
Yeah.
insane. Like, but now she's actually improving now as well, which is great. But yeah, it's crazy how much people can sometimes affect our day to day
Mm,
lives like that. But what I usually try and say to my patients there is, you don't have to cook three separate
yes.
meals.
Yeah.
Yeah, you can cook one meal, just you don't have to eat every
Yes,
aspect of it.
absolutely.
That's the key thing. So, if, like for me, like I've got three kids, and anyone that's got kids out there knows, like, it doesn't matter what you cook them, like they won't eat it.
Yeah.
And they'll just want
Yeah.
something different. My wife, she's eating different at the moment than me, and but I just cook one meal, and the kids eat some of it, I eat some of it, my wife eats some of it. We put it on the table, and we take what we want, and that's pretty much it. We're still sharing a meal. We're still cooking one meal. It's just there's multiple components, and I'm just picking one component of that. I'm just picking the meat part. So you don't have to eat separately, or make it a big thing. But yeah, support at home does certainly make a huge
Mm,
difference. Have you found any differences? We spoke a bit about your
yes.
health with PCOS and so on, of course, and professionally, but personally, otherwise, for you, have you found any other changes that low carb medicine, low carb health diet has impacted you in any other way, like
Yeah,
personally?
so my gut is a lot better. So I would have a lot of bloating, a lot of reflux. and that's probably 90% gone.
Mm,
Uh, and I'm not on any, you know, proton pump inhibitor medications. The times that reflux does play up is when I'm stressed. And I'm definitely more in tune with that at the moment. Or the other thing is if I eat too much in one sitting. Those are my two big triggers for reflux. And you just kind of have to let it pass. But I'm quite hesitant to take proton pump inhibitors. They've got lots of side effects, uh,
mm,
including micronutrient deficiencies, which coming back to it. Um,
correct.
but yeah, so bloating and reflux, and that's I do see that in a lot of my patients as well. So uh, because it makes sense, and carbohydrates are consumed by a lot of the bacteria in our gut, they ferment, which can contribute
Yeah.
to gases as byproducts. Um, so so those are the two big ones, non PCOS related, um, and I suppose anxiety as well. Although I would say it's not the only thing, but it definitely helped. When you're not eating multiple times a day and each meal having carbohydrates in it, shooting up blood sugars and then shooting up insulin and then you crashing again, you're not as your mood's not doing this, like going up and
Hmm.
down throughout the whole day, and you're pretty steady. Now, I experienced burnout and anxiety, in the last couple of years, and I think that was a bit different in terms of that driving it, so kind of work and career related. But like being low carb, or maybe having to even go a little bit more lower carb, and increasing my protein a little bit during that time, I think definitely helped. So I had to like adjust depending on my mood in terms of what I
Mm.
was eating. And fasting also helps, I think, with all of that as well.
Yeah, I mean, I certainly noticed all of that with myself as well. Obviously, I don't have PCOS, but from the testosterone side of things, there, I definitely noticed an improvement when I went low carb, keto, and then even further into carnivore
Yep.
as well. But yeah, same with me. Just anxiety, stress. I've never really suffered from mental health issues, or at least not diagnosed. Like anyone, of course, I've had stresses in my life, a lot of stresses. Like I said, I got three kids,
Mm,
and anxieties. But I found it made a big difference when I cut the sugar
yes.
as
Yeah.
well, for sure. And with the fasting and my like my IBS, everything just kind of like
Mm,
disappeared, and especially now in carnivore, like just completely disappeared, completely, which is amazing for me. You mentioned
yes.
fasting, so you do some intermittent
Yeah,
fasting as well?
absolutely. So I wouldn't say every day. It's varied over the years, but yeah, I got rid of the whole breakfast is the most important meal of the day a while ago.
Yeah.
I do like my coffee, so I will have coffee. There have been times where I've had a bit too much coffee. That's not good either. Uh, I almost like to suppress my appetite, which is not ideal. It is an appetite suppressant, but at the same time, it is a
Mhm.
stimulant, and so can actually create a bit of a stress response, which is not ideal in someone
Mhm.
who is recovering from burnout and has a history of anxiety. So that's definitely a work in progress, adjusting that. But I feel like fasting works really well when you're busy. And so if you're at home, not doing anything, near the kitchen, fridge staring at you in the face, not great to be fasting. Um,
Oh, sorry, fly just attacked me. um,
yes, so
Carry on. Sorry.
but yeah, so I think it's context specific. It depends on, how long you want to do it for, and I'm a very big advocate of it for my patients. I'm happy to support them in various kinds of fasting regimens that they've done. But yeah, I haven't counted the hours exactly, but it's always at least 12 to 14 hours. Um, and even if I have 3 meals a day. It's definitely a shortened window. So I'll have my first meal at maybe 10 or 11 and be done by 6 or 7. Uh, so, but that varies. Like I'm not really regimented. It's kind of interesting. There's a lot of evidence coming. Like initially, it was like, oh, you don't have to be regimented. You got to keep your body flexible. Change it up during the week. And then now I'm hearing about it. There's some evidence out there where it's about all about consistency because it's all about the circadian clock. And if you can be consistent enough, even on the weekends, you actually have greater benefits in terms of blood sugars, blood pressures, all that sort of stuff. So
Mm,
that's what research is. It's constantly changing, and you got to keep up to date. So, um, but yeah, so I think it's a tool that I have. It's quite flexible. It gives me freedom, um, and I find that I'm as I do it more often, I'm not struggling as much in terms of hunger
mm,
because when I'm hungry, I'll just eat.
yeah. Have you tried to do any like prolonged fast at all, like more than a day?
No, not there yet.
No, fair enough,
Definitely
fair
not
enough.
there yet.
Um, yeah, no, it's something that I know a lot of people that do
Yeah.
it. I've done them myself, and again, same thing. When I first was introduced to the idea, I was like, "You're crazy! Like like what on earth is this? This is bonkers. Why are you not eating?" But then I was amazed by the differences that I saw when I did my first prolonged fast. Really, truly incredible. And I've done quite a few since. And the longest one I did was 14 days, which was I actually just meant to do a 7, but then I kind of felt fine, and I just said, you know what, I'll just carry on until I don't feel fine. I got to 10 and then still felt absolutely fine. So I just carried on to 14. Yeah, by the 14, I wanted to eat. Um, for sure. I was getting pretty hungry then. I didn't really feel like there was any benefit over seven
Mm,
days, but I definitely felt there was benefit on the 7 day
yes.
fasts. But interestingly, like now that I've lost a lot of weight, I and on the carnivore diet, I'm kind of relearning my hunger signals. I'm struggling to do those
Mm,
fasts now. Like I said to my wife yesterday, I'm probably just gonna go on like a 2 day fast
yeah.
tomorrow. Yeah, I've made it like 24 hours and I'm just yeah, I need to eat.
Yeah.
I just
Yeah.
need to eat. Um and I don't know if that's just because I've just got a lot less fat reserves now or something else has changed. But there definitely has a place. And I know some people do it. There were people talking at the low carb down under this year around prolonged fasting as
Mm,
well. And it's a great way of just getting people that reset.
yes.
Um, but since I've experienced carnivore, I actually feel like that's probably a better way of getting that
Yes.
reset, and it's a bit
Yes.
safer. We don't have to worry of refeeding syndrome and hypos as
Yeah.
much as we do with fasting. So I think it's a little bit safer in that regard, and it's a bit more palatable for people rather than saying, right, you can't eat for
Yeah.
7 days.
Yeah.
Is a little bit much. It's even worse than saying you can't eat
Yes.
vegetables. People will just look at you like you're an alien, like you got a green
Yeah.
head or something. But no, I mean that's something that certainly some people do and they find great interest, great benefit. Sorry, rather. But intermittent fasting, yeah, definitely is something that I talk to a lot of patients about as
Yeah.
well. And a lot of people see really big
Mm,
benefits
yes.
from it for sure. So um, we've been talking now for about an hour and 20 minutes.
Yeah.
And so it's quite a long time. It's been a great conversation. Time's gone by
Yeah.
very quick. It's probably a good time to maybe just, think about wrapping it up. Is there anything else that you wanted to share, Malini, that we haven't spoken about so far?
Yeah. I don't know if I can say it, but would love to talk about my business really quickly, if that's all right.
Absolutely. You can certainly talk about your business. Yeah, that's part of why you're here,
Yeah.
of course. Yeah,
Yeah.
that's fine.
So, PheonixDocs, essentially, like I said briefly, came from medical students asking me and pestering me about questions about nutrition and lifestyle for their own health, really, let alone treating patients. And it just made sense because, personally, I've gone through, like I said, I've gone through burnout. I'm still recovering. from burnout and anxiety. And I've had it for a lot longer than I thought I did on reflection. So, I mean, this started when I was in the hospital as a resident. So, uh, many, many years. And, we're hearing about doctors quitting medicine, um, mental health, suicide amongst doctors. Like, it's just ridiculous. And something has to change. So, a lot of it's not in our control in terms of the system and what is expected of us as doctors and Medicare. May not necessarily be able to change it ourselves, but if we have the tools to actually look after our own health that we may not have realized are there, uh, like that's a start. And I feel like I have an obligation with what I'm learning and what I've been through to teach people about this. And you can go on YouTube and listen to podcasts, you can read books and all that sort of stuff. You can go through research articles, but who has time to do all that? Like, and
Mm.
still practice full time as doctors, study for exams, finish med school, all that sort of stuff. So I feel like with the journey that I've been on, all the reading that I've done, all the training that I've done, and I'm still doing, I'm no expert, but I'm definitely learning, and I have time to do that, and I have made the time to do it. I've been very fortunate to be able to do it. I just want to share it with people. And so, there's low carb down under. There's lots of other lifestyle medicine conferences and things out there. A lot of it is for patient care, but my business is more about doctors' health and medical students' health. And so my first workshop is in Brisbane on Saturday, the 11th of March. All the details are on my website, and there's a link even on my Instagram page and Facebook page to buy tickets. So it's a full immersive experience where it's about your health as a doctor or a medical student, um, in terms of starting to become aware of what you need to work on to feel better and live your best life. So whether or not it's looking at food, whether or not it's movement, and we're gonna do all of these things. Not just about lectures. It's about I looking at labels on food. That it's about actually doing some fitness assessments. It's about experimenting with stress reduction, like meditation and things like that, but all in one day, so that you can walk away. And yes, you can tell your patients about it, but you can work on it yourself at the same time. So that's just the
Mm.
beginning. As of us recording this podcast on the 13th of February, there are 4 spots left. Um, but that's just the first workshop. So if this goes well, I would love to host more, not just in Brisbane. I would love to do it in Sydney and Melbourne and wherever else there's demand, um, because I feel like we're at a crux in terms of how our healthcare system is at the moment. And if we don't do something about doctors' health and the new generation of medical students' health themselves, I feel like it's not sustainable and it's going to crumble.
Yeah, no, I think you're absolutely right, and I think what you're trying to achieve is very noble. It's very important, and yeah, more people should be doing it. Looking after each other's health as doctors, as healthcare professionals, looking after ourselves is incredibly important. You can't care for others if you're not caring for
Yep,
yourself
exactly.
first and
Exactly.
foremost. How can people find you on social media? You mentioned Instagram and
Yeah,
Facebook
so those
there.
are the two main pages that I'm on. So it's just PheonixDocs, the animal phoenix, so Phoenix, and docs, DOCS, all one word. And my website is www.phoenixdocs.com.au.
Yeah, perfect. Well, I'll make sure to put all those links in the description for the podcast video. Hopefully, I'll try and get this out as soon as possible,
Thank you.
so that we can get some advertising for you. But I'll certainly put it in the clips on Instagram and so forth. So, yeah, anyone that's listening, anyone that's watching, definitely go check out Phoenix Docs on Instagram and Facebook. Follow along with Malini and what she's trying to do there with everybody's health. Make sure you share it to the masses so that we can get this word out that there is a better way of trying to help people. Also, of course, follow
Oh,
myself
yeah,
on
absolutely.
Instagram. Um, at Dr. Suresh Khirwadkar on Instagram and Facebook, at the Meat Medic on YouTube and Twitter. Thank you very much, everyone, for tuning into this episode of the Meat Medic podcast. And thank you, Dr. Malini Bose, for coming on and talking to me for about an hour and a half, I think it is now. So, wow, that's a
Yeah.
long conversation. Time flies when you're having fun. It's been great talking to you. Thank you so much. It's been a really, really pleasure talking to you today. Hopefully, our listeners, viewers have learned a lot about PCOS, testosterone, estrogen, endometriosis, and how low carb medicine, lifestyle medicine, and integrative medicine can help their health. Thanks everyone for tuning in, and we'll see you guys in the next episode.
Thanks, Suresh.